First of all, I would again introduce the international board members of the Sarcoma Academy, Axel Lucen and Jean-Yves Blais. And of course, the highlight today are the three speakers. First of all, Nadia Hindi from Madrid. She will join us very soon. Then Brendan Dickson from Toronto and Costantino Errani from Bologna. So they have prepared exciting cases, and they will soon share these cases with us. Also, I would like to thank the sponsors, foremost PharmaMar, but also Novartis, Bayer, and Implantcast. So I'm very happy to introduce Brendan Dickson. I think everyone knows him as an expert pathologist in the sarcoma field, and I'm really excited to hear his thoughts and his cases today. Please, Brendan.
So the presentation of my talk, or the topic of my talk, is a query of a metastatic leiomyosarcoma. And the purpose of this talk is hopefully to generate a little bit of controversy and some disagreement amongst the group, but perhaps people will end up being a little bit more agreeable than I might have foreseen. So this is a relatively recent case that I encountered in the last year. Basically, the patient is a 55-year-old woman who was referred to our sarcoma medical oncology group with a presentation of widespread metastases. And as part of the standard operating procedures with our group, an automatic pathology review was generated to review this patient's past specimens. And those specimens were significant for two specimens. The first was a hysterectomy from 6 years ago, which at an outside institution was diagnosed as leiomyosarcoma. And then more recently, 3 years ago, she had segmental bowel resections secondary to obstruction, whereupon metastases were confirmed and again diagnosed as leiomyosarcoma. So to begin, I realize many of you don't have a background in pathology. The histology here is actually quite simple and something that's quite amenable to even a medical school histology course. So I hope it won't be too tedious for you. But basically, you can see that we have here a uterine resection. And you can see at intermediate magnification, this is a spindle cell tumor, and it has a nice fascicular pattern. And at higher magnification, the cells have ovoid monomorphic nuclei with somewhat of a cigar shape and scattered atypia. Elsewhere, we see that we've got areas of necrosis, and for gynae pathology, there's a huge amount of controversy in uterine smooth muscle tumors, so-called ischemic type necrosis versus spontaneous tumor type necrosis, which unfortunately suffers from poor interobservable reliability when it comes to the interpretation. But here, this is a pretty black and white example of spontaneous tumor type necrosis. And again, the uterine tumor shows mitotic activity. And immunohistochemistry here performed showing staining for H-keldesmin, which is one of the most specific and sensitive markers for smooth muscle differentiation. And so on the outside, this was diagnosed as leiomyosarcoma. And I think most of you would look at this case and think that that's very reasonable. Next, we have one of the segmental resections from the small bowel. And again, you can see that we have a relatively lobulated neoplasm. And at intermediate magnification, again, we have these spindle cell fascicles. At higher magnification, we can see that there's some atypia. Again, we have necrosis. And likewise, we've got some mitotic activity interspersed. And again, just highlighting the presence of relatively brisk mitotic activity. And by immunohistochemistry, this is positive for desmin, smooth muscle actin, and H-keldesmin, all again in keeping with the smooth muscle differentiation or myoid differentiation, as well as estrogen receptor, which you might expect from a uterine primary. And so again, this again being the outside diagnosis, we've got a tumor that was classified from the small bowel as a metastatic leiomyosarcoma. And so at this point, there are two elements for engagement with my talk. The first is an audience vote, and that is, how would you classify this tumor? I see the vast majority of people favored metastatic leiomyosarcoma, followed by GIST, and then less likely other. Good, excellent. So I think certainly metastatic leiomyosarcoma is not unreasonable in this context. I'm just going to bounce back to the H&E that I showed you earlier. This is from the small bowel met, and there's something that caught my eye when I was asked to re-review this specimen, and it was this area here where we have a bit of a more epithelioid morphology. And certainly you can have areas of progression in leiomyosarcoma, so-called dedifferentiation, and it's an entity that Chris Fletcher described about a decade or two ago, which is widely accepted now as happening in smooth muscle tumors as in other sarcoma types. But when you look more closely, you can see that in addition to areas of clearing, we've got quite a bit of heterogeneity in terms of the cell size. We've got marked pleomorphism. We have mitotic activity, including this atypical figure here. And again, these really, really bizarre cells. And when I saw this, one of the first things that came to my mind was, well, could this be indicative of another diagnosis? And so in addition to the smooth muscle markers, I threw in a marker of my melanocytic differentiation, HMB45, which really isn't all that convincing. You might look at this and wonder, is this background or aberrant staining? But when I did another myeloid marker, melan-A, you can see that the tumor, at least in this epithelioid area, is diffusely positive. And so what is the significance of this finding? There are, in the literature right now, two dueling schools of thought. And historically, this was thought to be aberrant melanocytic differentiation, or so-called leiomyosarcoma with so-called transformed smooth muscle. But then about 2 decades ago, almost to the year, it was decided that perhaps these are indicative of Picoma, so malignant Picoma in this particular context, given the wild atypia. And how do you reconcile this differential of aberrant melanocytic differentiation versus a malignant Picoma? Well, I turn to molecular, and you can see here that this tumor has a TSC2 mutation. I apologize for the poor formatting of our molecular report here, but basically we have a TSC2 mutation, and this particular mutation results in a premature translational stop signal. And loss of function variants in TSC2 are all pathogenic. So this is presumably the driving mutation in this tumor. And so coming back to the diagnosis, and I know that there are a few people that did select other. They are correct. And the diagnosis here is a malignant Picoma. So what are Picomas? Well, obviously they're mesenchymal neoplasms composed of perivascular epithelioid cells that have dual differentiation. They have both melanocytic and myeloid differentiation. These tumors have a wide anatomic distribution, and they also include, of course, the gynecologic tract. And while the vast majority of these tumors are sporadic, there are a minority of tumors that are associated with underlying tuberous sclerosis. And indeed, I've had at least one case where I was able to make a diagnosis of tuberous sclerosis based on the patient's presentation, and the clinicians went back and re-examined her and found café au lait or Chagrin's patches, some pigmented macules, subungual fibroma. So in some situations, the pathologist actually does have the ability to try to influence patient care, not just in that particular patient, but also at a more familial level. So Picomas have varied biologic potential. The criteria for malignancy, I should emphasize, differ between the gynecologic tract and elsewhere in the body, akin to smooth muscle or leiomyosarcoma in the uterus. The criteria differ based on anatomic location, and it's important that pathologists are aware of this. And again, you can have dual expression of melanocytic and myeloid markers, but it's important to know that you can have heterogeneity in these markers. So in this particular case, we saw that we only had focal expression of HMB45 and more diffuse melan-A. Oftentimes, this is the reverse in the gynae tract, and oftentimes the myeloid markers are somewhat less pervasive. You may only have focal or patchy staining for these markers. And while the vast majority of these tumors in the gynecologic tract have underlying TSC1 or TSC2 mutations, it's important to remember that a subset of Picomas can have fusion genes involving TFE3, which we can easily pick up by immunohistochemistry for TFE3 or by fusion analysis. And so with the second question, and here hoping to generate a little bit of controversy, I wanted to invite the panel to comment. I'm not sure how much time I have left, but I threw out a few questions that I thought might generate a bit of interest and to see what the panel thinks. And the first question is, should malignant mesenchymal neoplasms of the gynecologic tract or uterus be managed by multidisciplinary gyne-oncology or gyne groups or dedicated sarcoma groups? My second question to the panel would be, would a malignant picoma change your management decision? And that is relative to a leiomyosarcoma, which I suspect is probably less controversial. And then finally, what is the role for molecular testing in mesenchymal tumors of the gyne tract? And there have been a number of recent discoveries in mesenchymal tumors, which in this particular location rely heavily on underlying molecular techniques. And so I wanted to see how, in a broader global sense, where people may not have access to these techniques, where the role of molecular testing comes in. And I will leave it to the panel at that.
Brandon, thanks so much. Just awesome. I know that in the panel we have Beata Bode as a pathologist. Maybe, Beata, may I ask you to give your opinion, your impression on what you just heard, and then we spread the word on the panel. I also see that Sébastien Labonte is in the audience. You are not, you don't have access to talk, but please feel free to send any question you might have, then we can incorporate like this. Beata, please.
Yes, Brendan, thank you very much for this really interesting case. And it's you know, the one of the highlights of this case is that it's so common. So it's kind of daily practice what we address with this case. So this is very important and great, interesting clinical situations which we are dealing almost daily and this respect. So I really also interesting in, you know, what the oncologist would mean to your second question. And according to the first question, it's also tough for me because you know these are two worlds. So so at least in Switzerland. So you know, kind of combining them. And I must admit I prefer the soft tissue and bone tumors than uterine tumors because they are so different. So the biology of those tumors is totally different. And I think you know, both sides, gynecologists and orthopedic surgeons do not kind of meet in understanding those tumors as different diseases. So that's another good point. And of course, well, according to your third question, I would love to have, you know, first the NGS panel of any uterine sarcoma first, and then go for making the diagnosis, because they all look more or less the same, but the molecular behind it is amazing. Just as the case you presented, you know, I'm sure, you know, most of the people would do the diagnosis of hysterectomy of leiomyosarcoma.
Awesome. Maybe Axel, you want to refer also, particularly for the first question.
Can you see me? Can you see me and hear me?
No, we hear you. But please go ahead.
Oh, okay.
Sorry.
Yes, so that's an interesting case. Of course, I'm not a pathologist, as you perfectly know, so I will ask probably a stupid question, but given the presentation of the disease and the expression of estrogen receptor, one could ask whether endometrial stromal tumor could have been an option. I understand that this was not something you retain as an initial diagnosis, but is that something where discussion could be made, because we have been identifying and seeing some ESS which are more aggressive in the presentation than classical ESS, low grade hormone receptor expressing. Just a question, maybe a naive question from a medical oncologist who's not who cannot review a pathology slide, of course.
Yeah, actually, this is a phenomenal question, and perhaps you're being quite modest, because in fact there's an article that just came out in the literature that shows, and I believe it was in Modern Pathology, that shows that you can have a subset of endometrial or uterine tumors that have both the low-grade ESS fusions, that is the JAS-F12 fusions, JAS-F1 SS12, and they also have a TSC2 mutation, and they have a somewhat different morphology, although they're classified under the rubric of low-grade ESS for the moment. So they actually can have both a fusion and a point mutation, and this just came out in the literature. But to your question about the estrogen receptor staining, are you asking about whether or not the ER can be targeted as a therapeutic opportunity, or did I misunderstood?
Yeah, actually, it was first a question of diagnosis, and anyway, we would certainly, whether it is a leiomyosarcoma or an ESS, we would certainly consider at a given time point hormonal receptor targeting, even though, of course, we all know that it's more efficient if ESS versus LMS expressing ERs.
Right. So I imagine all of the pathologists on the line, like here, will routinely do immunohistochemistry for ER/PR with the gynecologic tumors, and both for ESS and for leiomyosarcoma, obviously may form some component of the medical management. But I certainly would defer to our medical oncologist for that.
So Brendan, the last question, how would you answer that?
Is there a role for molecular testing? Absolutely. So we do with endometrial sarcomas, every single ESS that I see, I will do fusion testing, because obviously both the low grade and the high grade ESSs are defined by their molecular underpinnings. And in fact, it's coming out now in the literature that you can actually have a low grade morphology with a paradoxically high grade morphology and vice versa. So morphology alone lies, and you really do need the underlying molecular to help be quite rigorous in that regard. So we, with all ESSs, will do the molecular. When it comes to picomas, I will send them out for molecular as well to make sure that there's indeed a TSC1 and a TSC2 point mutation, because obviously with the change in management with a malignant picoma, obviously this patient's going to be now put into a different basket where they can be treated with an mTOR inhibitor rather than a standard smooth muscle protocol. So differentiating leiomyosarcoma from picoma is critically important, I think, based on the current literature, given the change in management. So in this particular example, because we're dealing with the picoma, yeah, I would always do molecular to make sure that we have a TSC1, TSC2, or a fusion that is for TFP3 rearrangement. Even a subset of smooth muscle tumors have fusions. We've inadvertently tripped on them, just in the course of our routine diagnostic practices here. So I think that from my perspective, there's an ever increasing role of molecular testing in not only in gynae tumors, but also in the extremities and elsewhere. But at the same time, I think it's important to acknowledge that not everybody internationally or even within countries, so for example, outside of the larger academic centers in Ontario, for example, people don't have access to these techniques. And so how you delegate access and is it even worthwhile if it's not going to change management? I think these are all really, really difficult questions that I think really do require more of a broader multidisciplinary and indeed an international consensus on when is there a role for doing these techniques, because obviously it's important to have equity, amongst patients and their management across the board. So
I think this is an extremely important question that you are alluding to, and I think it's maybe on a superior level, on a management wise. What is the impression of, let's say, for example, Axel or Jean-Yves? Where should we guide people? Because people want to basically know, well, where do I have, which extremity sarcomas do I have to do NGS testing? If there's just on an individual base, which I think is the best thing to do, but most people want to know where should I do what. I think it's still too early to determine this, or what do you want to say?
Axel, you want to start?
Yes, please.
Axel, you are muted.
We don't hear you, Axel.
Okay. I have a question for Brendan. If you have a typical leiomyosarcoma of uterus, is there a role for molecular testing?
A typical leiomyosarcoma? So typically no, and indeed the original uterine tumor was read by an international gynae expert and didn't do a single stain. It was just a morphologic diagnosis. When I re-reviewed the case, and with the benefit of looking at the MET, where there was that small focus of epithelial morphology, I went back and did immunohistochemistry on the original tumor, and there was very focal melanocytic differentiation. So I think going back in time, if molecular, not molecular, but if immunohistochemistry had been done, that might have tipped the balance and then prompted a question about the diagnosis, and then might have prompted molecular testing. But no, on uterine smooth muscle tumors, personally speaking, and a number of my colleagues, we will routinely do immunohistochemistry, but not molecular when it looks for all the world like a smooth muscle tumor.
I think we have to be careful with the message to give to all population, all patients having a new sarcoma want an NGS testing. And if, with the exception of research, I think it's too early to push all centers, all patients, or to make a routine molecular testing. We find maybe less than 5% of all cases some target. So for me, typical frequent histological subtypes do not need outside research purpose molecular testing. For unusual presentation, like the case presented by Brendan with epithelioids, melanoma expression, blah blah blah. If there is a doubt, yes, of course, for very rare entities or in unusual presentation at the histological level, yes, molecular testing seems for me useful, but not for many other simple histotype of sarcoma. Your advice?
I would completely agree. Yes, I would completely agree with that. Actually, we may want to distinguish two different situations. The first one is a question of diagnosis. A diagnosis for localized disease that is probably outside of a dedicated translational research program, and some of our institutions may have such program. It's probably not recommended. Now, when the patient has relapsed or has multifocal disease where systemic treatment can be considered, this may become more useful at times where we're identifying more and more agnostic mutations and actually actionable mutations, which may, as Axel say, be treatable in less than 5% of the cases. All right, but that's still significant because the magnitude of the side effects and the utility for the patient may be very different. And also on top of that, you also may want to include the patient into dedicated clinical trial. So I think there is a difference between general recommendation at diagnosis, general recommendation in metastatic phase, and probably specifically in reference centers.
And the other question, in France, are the gynecological tumors with respect to sarcoma separate from the sarcoma entities? Or how is that organized? What's your view on that?
The problem is specifically for the gynecologic sarcoma tumor, the diagnosis is already made in post-operative setting when the tumor is morcellated. There is only one sarcoma for 1,000 fibroma, so it's impossible for a gynecologic team to think about sarcoma, and we cannot see the patient. We cannot take in charge 1,000 fibroma per year to see one sarcoma in referral center. So I think it's a complex situation. When the diagnosis is made, yes, of course, I think for me, the patient has to be referred in sarcoma referral centers for the next management, because it's a rare disease and gynecological teams are not so aware of the research on this tumor. So, but it's sometimes, frequently it's too late for the patient. The tumor is already morcellated, so it's a complex situation.
So actually, the entry point is very different, as says Axel, but at the end of the day, they will be integrated in a NetSarc Plus database, and they are reviewed centrally by actually sarcoma specialists, pathology specialists, who are subspecialized in GYN sarcoma. Actually, we have a small group of these. That's it.
Very interesting. Any words on the second question regarding management?
Of course, it's totally different diseases between leiomyosarcoma and Picoma. Picoma are very sensitive to mTOR inhibitors, so we play with a lot of different mTOR drugs, inhibitor drugs. So it's more, we can control the disease with even in metastatic Picoma, we can control the disease for a long time with mTOR inhibitors. And specifically in this case where there is an interval-free disease of 6 years, and we are in post-operative intense situation, so we can control the disease for a long time. It's not the case for aggressive leiomyosarcoma. And to make a comment on leiomyosarcoma in women in general, not only in uterine leiomyosarcoma, but here at Gustavo C, we try to find ER or PR receptor in all leiomyosarcoma in general, not only in uterine. In women, we find sometimes positivity for ER and PR, even in non-uterine leiomyosarcoma. It could be helpful. It's a very easy test, maybe less than 5–10% outside uterine leiomyosarcoma, but in leiomyosarcoma in general, we find some ER positive tests can help for maintenance therapy after chemotherapy and so on.
And
well,
may I make a quick comment? Also, it's important to distinguish histologic subtypes, moreover, because there are more and more clinical trials focused on specific histotypes. So there are specific clinical trials enrolling only leiomyosarcomas and UPS, for example. So it's important to make this distinction, and as well as I think there are not now clinical trials enrolling Picoma patients, but a Picoma patient could be enrolled in a basket trial for other targets. So I think it's critical to have an accurate diagnosis.
Brandon, I think we all have to congratulate you for this fascinating case. It shows the importance of the multidisciplinary approach. I think it's just exemplary. Thank you so much. I think we have to move on to the second case. Costantino, I'd like you to present your case, please.
Thank you, Bruno, for inviting me to the Sarcoma Academy. I present the case of a 32-year-old woman presented at our institution because of back pain and right hip pain. So a lytic and destructive mass was found in her pelvis. So the first question is, what is your diagnosis?
The majority chose the second answer with 58%, chondrosarcoma, and the second place is osteosarcoma and lymphoma with both 17%. And then it's bone metastasis with 8% and giant cell tumor has 0%.
Oh, great. So examination of a CT-guided biopsy led to a diagnosis of a giant cell tumor of bone with a H3F3A gene mutation. So the location is not typical for giant cell tumor, the age is so typical. And so the second question is, what treatment do you suggest? So like any surgeon, I'm always think to be the best. So I perform a curettage of this difficult case of giant cell tumor of the pelvis using embolization before the surgery and cryotherapy during the surgery. And after 6 months, the patient was fine without local recurrence. So I thought that I was the best. but unfortunately, a year later, the surgery, the patient had a huge local recurrence, and so I saw that I wasn't the best anymore. And now I have another question. So right now, what treatment do you suggest?
So the answers for treatment, 64% chose, I'm sorry for my spelling, the fourth answer, denosumab and surgery and resection. Yeah, and the second one with 29% is the last answer, and 7% chose the third one.
Okay, okay, sounds good. So, so we decided to treat the patient with denosumab before the surgery, and during a short-term preoperative denosumab treatment, the pain disappeared, and the CT showed a very good response. So I have my last question. What kind of reconstruction do you suggest?
Equal 44% for answer 2 and 5, so custom-made prosthesis and flail hip.
Okay.
And 11% for bone cement spacer.
Okay.
And 0 for the others.
Okay. So I made a resection and reconstruction with a massive bone allograft, saving the hip joint, and at 2 years follow-up, the patient is fine without local recurrence. So the take-home message so far, we know that the denosumab may increase the risk of local recurrence in patients with giant cell tumor of bone treated with curettage, but in difficult locations with the stage 3 tumors, in which we plan a resection, the denosumab can help surgery. And so in a very challenging site such as the pelvis, short-term preoperative denosumab could be helpful in surgical treatment of stage 3 giant cell tumor. And we published recently our treatment algorithm for giant cell tumor of bone based on a literature review suggesting for stage 3 giant cell tumor in pelvis, in the sacrum, in the spine, preoperative denosumab treatment and resection. Thank you.
Costantino, thank you so much. Very nice case, and it just shows that it not always follows our wishes, how we want it to be. Maybe all others can join again, and I think maybe we just start before we go, let's say, as the surgical part, we go for the denosumab part. Yeah. And does let's say the medical oncologist agree, let's say, with the algorithms presented here, or I think I would like to discuss a little bit the indication at the various centers we have here.
Yeah.
I have seen two cases like the Costantino case during the last 3 or 4 years. Even in the first step, I will be in favor to start with denosumab, where a large tumor, so surgery is complex in this situation, and denosumab can help, facilitating the first surgery. So I'll be in favor to start with denosumab. The problem is the duration of denosumab in neoadjuvant setting. In general, between 3 to 6 months, and then the patient underwent surgery. So I'm not surprised that this patient relapse after the first surgery, considering the huge volume of the tumor. So it is an unusual presentation, and even radiologically, it's complex to make this diagnosis. The importance of, for this case, highlights the importance of make a biopsy before any surgery, because it was typically a chondrosarcoma radiologically, or osteosarcoma, more chondrosarcoma. But when we have the chance to have the diagnosis before surgery, I'd be in favor to start with denosumab in this situation.
Nadia and Jean-Yves?
Yeah, I fully agree. We would have gone for upfront denosumab and then consider a resection in this case.
Very good. From the diagnostic point of view, Beata and Brandon, anything to add from your side?
So it looked like the diagnosis was typical on histology and confirmed by molecular pathology. So, you know, in the biopsy, probably you will be able to see any kind of malignant areas, and this didn't seem to be the case anyhow. It's quite typical.
Yeah, likewise here. I mean, with a typical morphology and the typical immunophenotype with the H3FA, it's really made it much easier for us to confirm the diagnosis. But I think it's important for the clinicians to know that the mutations differ based on anatomic location. So, for example, giant cell tumor of bone in this short tubular bones of the fingers will have a different point mutation, not to be confused with giant cell repetitive granuloma, which will have an ABC fusion. So a negative H3FA doesn't necessarily preclude the diagnosis of giant cell tumor, and it's you know, it's just one more layer into the diagnosis that we have to take into consideration.
If you talk about staging, what type of staging did you do, and what do we usually recommend, let's say, within the panel? Costantino?
Campanacci staging. I mean, we use Campanacci staging, of course, and if the giant cell tumor is in stage 1 and 2, we suggest a curettage, intralesional surgery without denosumab treatment, of course, because the surgery is much more difficult if we perform a curettage following denosumab treatment. We cannot recognize the tumor, the tumor tissue, and we can have bone breach, new bone breach that can hide a tumor cell. So when the denosumab stops, we can have a local recurrence. So in stage 3, when we plan a resection, such in this case, such in a difficult locations, we suggest the short-term therapy. So just 3 doses of denosumab, because we are, you know, we have concern about possible malignant transformation or other, you know, collateral effects. So the literature recently showed that a short-term therapy is enough to help surgery. And so if the tumor is in stage 3 in difficult location, and we plan a surgery, short-term therapy, and resection.
What about the lung? Do you exclude lung lesions, and how do you do that?
Okay, when we have a lung lesion, the first approach is observation, like in desmoid tumor.
But do you just use regular X-rays, or do you use CT scan, or how regular, how often do you do that?
CT scan, and if we have a progression of the lesions, the lung lesions, we suggest the denosumab treatment. And you know, a long therapy with denosumab treatment, we suggest not a dose every month, but every 3 months, because like in for zoledronic acid, we literature reported that 1 dose every 3 months could be enough. And then we follow the patients, and as you know, giant cell tumor patients are usually young patients. So the question, I think the main question is for how long we have to do denosumab in a giant cell tumor patient with the lung mets, or in not operable giant cell tumor, a huge tumor in the spine or in the sacrum. So I have no the answer. We discuss in our multidisciplinary meetings. Sometimes we stop the treatment and we see what happens. And if we have a recurrence of the disease, we re-challenge the treatment.
Any other thoughts on that?
Yeah, we tend to do like Costantino on spacing the courses of denosumab. Actually, every 3 months, and then afterwards, even every 6 months. We have been very much concerned by the side effect profile on the jaw. Actually, we had some patients treated for more than 15 years now,
15
because
years.
these 15, 1-5.
Yeah.
Because 4 patients in Lyon were treated in the initial study by David Thomas, and actually all these patients are receiving 6 months intervals. And interesting, because we cannot stop, because the lesions are multiple for one patient or unresectable for the other one. And interestingly, the first patient, the one with multiple lesions, is maybe relapsing under denosumab 6 months, but I have no proof yet. So we really have difficulty to have a general strategy, and we tend to, these are endless discussions within the multidisciplinary tumor board, and usually the surgeon proposes exactly what Costantino proposed, which is a short 3 courses, and then let's get to the surgery.
Yeah.
Janif, can I make a quick question? In this patient progressing on doses every 6 months, do you plan to come back to the monthly schedule, or what's your plan?
Actually, I'm very worried. The first, I really need to biopsy to confirm. Actually, we are debating on how to do the biopsy, because she is multifocal on the sacrum, on the vertebrae, and on the hip, and all are small lesions. So we are going to biopsy her. But if yes, this is exactly what we are going to do. Back to 1 month, 1 per month.
If you rule out that there has been a transformation, I guess, right?
Oh yeah, but I don't think it's a transformation, because this is very, very slowly growing, but growing.
Okay.
And painful a bit.
Awesome. Well, to the orthopedic surgeons, Shintaro and Lorenzo, I think the case we saw was, of course, it was a perfect result, 2 years with this function. I mean, you cannot discuss. That's awesome. You have to be congratulated to that. I would be worried, let's say, about the dorsal fixation regarding the shear forces. Shintaro, in Tokyo, how would you, let's say, how would you have addressed this reconstruction the same way? And if you do it otherwise, how do you do it?
Yeah, my opinion is that unfortunately in Japan we cannot use the allograft because of I'm not sure because of the reason, but so for me it will be work to use the autograft using the double barrel fibula graft to bridging to maintain the pelvic ring instead of using the allograft. And I asked you to the Costantino, and I'm very surprised that you agree that using the denosumab, because you are very dislike to use denosumab, I believe. But so I think the second time it's very useful to marginate the tumor area from the gluteal muscle to the tumor. It's very easy to resect, and also the too long use of the denosumab, more than 5 or 6 or 6 months, may be entrapping the tumor of the new bone formation, and then it make increasing the local control rate. So that's why, that's my opinion. That's it's a short-term treatment of the denosumab. It's very useful.
Yeah.
How do you think that?
I mean, regarding the first question, never say never. So I changed my mind, because as you know, at the beginning, I had a case of malignant transformation in a young woman, and so I started to have concern about the denosumab, and then we had a higher off recurrence rate following curettage. So I mean, we didn't know so much regarding these treatment and surgery in combination with surgery. So now, finally, I mean, we know that denosumab can help the resection in different situations like this case, and short therapy is not, you know, is not dangerous for our patients. So I think that denosumab can help in these situations. And then, you know, for a long therapy, we have to discuss with the patients, with, you know, our colleagues, oncologists, and when the patient is not resectable, or, you know, challenging sites like, you know, sacrum, we can discuss, you know, the therapy every 3 months or every 6 months. I would like to do an a study together, you know, to collect our patients and to understand more about this in the next future. Why not? This meeting could helpful regarding research.
Indeed, there was a clinical trial by the ERTC, the REDUCE study, which was prematurely closed, and it's a pity because I mean, I don't know how many patients were included, but just a few. And that was a very interesting question.
Actually, we are doing the REDUCE study in France for this exact reason, and yeah, and I guess you are doing so as well.
Oh, it's very interesting about that.
Frank and Lorenzo, how you do it? This situation?
So
sorry. I answer yeah, I agree. A double bundle vascularized fibula is a perfect indication. I missed in the questions this kind of option. Sorry about that.
No problem.
Yeah, thank you.
Yeah,
Frank, please.
I could be a little bit afraid that we just two screws, especially behind in the sacrum, but even in the iliac part, resting part above the periacetabular part. So we prefer the plating, so double plating or just one plating to fix the pelvis, main pelvis and the bone graft. You see it has a little bit in the anterior part, a little bit shifts, it's open and it's going up, but it's very good, you know. And we did not prefer using a spine and pelvis fixation. We don't like it. We don't use it.
What about you, Frank?
I think in the pelvis, it's a very different situation for if you discuss resection or denosumab treatment. And I think for this case, it was perfect, and also the reconstruction works, so everything's fine. Since we don't have any allografts in Germany, or long bone or half of pelvis allografts, we would also do a double bundle fibula, non-vascularized, and they normally work also quite well. And then we just put some bone chips and bone marrow close to the interfaces of the bone, and then normally it heals, so that's quite okay. But so one question to the pathologist, what I actually never dared to ask is, what's the difference between a giant cell tumor of bone with lung lesions and a malignant bone giant cell tumor of bone? Is it the same, or is it just like completely different? And what are the pathology findings you have to see to call it a malignant kind of bone giant cell tumor of bone?
Brendan, you start?
Oh, sure. Well, histologically, a giant cell tumor of bone that's metastasized to the lung can, for all the world, be morphologically indistinguishable from a primary giant cell tumor in situ. So just because it's metastasized, by definition, I mean, going back to the definitions we learn in medical school, what is a malignancy? And, you know, we define it based on metastasis or what have you. I mean, that's really simplistic, as we all know, and how we define these things doesn't always sort accordingly. So just because it's metastasized doesn't make it a malignant giant cell tumor bone per se. What we use to define it as malignant is the presence of pleomorphism. So we've got marked atypia, we've got atypical mitotic figures. So in addition to just brisk mitotic activity, which you can see in a normal giant cell tumor bone, we have tripolar mitoses and atypical mitoses combined with that pleomorphism. So a sarcomatous morphology is what the WHO alludes to. And that may take the form of just an undifferentiated pleomorphic sarcoma, or you may see osteosarcomatous differentiation as well. And you can see osteosarcomatous transformation, and it will still retain the same point mutation that we can pick up by immunohistochemistry and molecular.
Yeah,
Okay,
this is the important point again, the background, the molecular background. So you can have an osteosarcoma on top of a giant cell tumor, but if you don't have the mutation, you would call it like that. And you can have a malignant giant cell tumor without metastatic disease. So the multifocality is not defining the malignant. So you look at the tumor, it's malignant, and then you kind of realize it may be a giant cell tumor molecular.
Okay, I think that's quite important, because some of orthopedics dealing with bone tumors get referral of malignant giant cell tumor of bone, and actually it's only because of the lung mets and not because of the growing of the lesion. And we have quite good results in dealing in treating the patients with the lung mets, also with denosumab, because they then actually shrink or can disappear even without surgery. And years ago, as I was a fellow in Toronto, we used the 8 courses of denosumab, but now we also reduce it, and we also use different doses. So for the oncology, we use 120 milligrams per injection, and now for the osteoporotic treatment of with denosumab, it's only 60 milligrams, and that works quite well. And we have some patients with really big lesions in the sacrum, and they just get 60 milligrams every 3 or 4 months, and they are stable and everything is fine. So we reduce doses and happy with this. So yeah.
So there are 2 questions also in this regard from the chat. One question is, in your experience, how common is it to see fractures associated with long-term use of denosumab? What's your experience?
Never saw it in giant cell tumors, because so our longest case is now 6 years with denosumab treatment, and he has no problems. But in the geriatric patients, where they get for the osteoporosis, we see it, but not as often as with bisphosphonates.
Interesting. Any other?
We've been seeing fractures of fatigue, as they call them, for many patients treated for a very long period of time, actually.
Yeah,
Yeah,
never seen that. Never seen.
Metastatic patients, cancer
metastatic
patients.
No, fracture not on the primary site, on other bones.
Yeah, no, I agree. I saw chest fracture in patient treated with denosumab or zoledronic acid for a long time.
It's called an atypical fracture in the proximal femur.
Yeah.
And the last question from the
and you have to treat these fractures, because these fractures do not heal
with denosumab.
They don't heal. So even for the trauma surgeons, where they say, oh, there's a fracture, I just need to fix it and it will heal, they need a really rigid fixation, because these fractures need ages to heal. So it's not like just put a nail in and then it will heal by itself. There has to be really a stable fixation, because these fractures will take ages to heal, and if the osteosynthesis is not very stable, then you have breakage of the nails intramedulla, because the fracture don't heal.
Great. Let's go to the last question. Is a chest CT mandatory before treatment?
A huge case.
Yeah. We did a biopsy and CT of the lung when we had the local recurrence at the beginning, and we had a local recurrence, of course. We usually do CT of the lung every 6 months in our patients, but I'm not sure that it is mandatory, it is necessary. Maybe an X-ray of the lung is enough, because the risk of lung mets in giant cell tumor is very low, 4%. I don't know, what do you think?
In general, for my patient, if the CT scan at the beginning is normal, I do not follow the patient by any assessment at the lung level.
We do basically the same, but we tend to have a 1 yearly CT scan for not good reason, I must say, because I think I agree, if negative at the beginning, it's most likely going to be negative in the long term.
Does it apply to all patients or just to high-risk patients in the pelvis with huge
high risk,
lesions?
you large lesions.
Awesome. Well, thanks so much. I think also this absolutely great case with this discussion that we had, I think we only can learn. Well, that's the spice of all, right? This really congratulations. So let's move to the third case. Nadia, I ask you to start with your case, and we are really looking forward.
Okay, so I would like to discuss with you a case which is not very complicated, but I would like to have your insights on the case. So this is a young woman, 34-year-old, only light smoker, has only medical previous history, and with a pneumonia last year, no other relevant antecedents. In July last year, she started with thoracic pain. After that diagnosis of pneumonia, at the beginning they thought it was again a pneumonia, so they treated it with antibiotics, but it didn't improve. So in December, she went again to the hospital, and imaging was finally performed, and they identified a suspicious cardiac or pericardial mass associated with pericardial effusion. A pericardiectomy was done with a bioptic intent, but in the biopsy, no malignancy figures were identified. And in January this year, she underwent a cardiac MRI, and as you can see in the images, there was a mass with origin in the pulmonary artery, suspicious of malignancy, of course. This patient was managed in another center. They performed a PET CT scan with no evidence of distant disease, only the mass in the heart. So with this with this situation, a 34-year-old woman with a cardiac mass and a first bioptic attempt not diagnostic, what would have you done? A second biopsy, an upfront surgery, induction chemotherapy, because for sure this is a sarcoma, induction radiotherapy. I don't know, Sabrina, yeah, if we have the votes. Okay, so a second biopsy, I'm quite proud of you. Okay, and I guess the panel would agree with that. So let's go on with the presentation. So this patient was managed in another center, and in March this year, they decided to go for surgery. They performed a left pneumectomy plus resection of the mass, including resection of the left atrial, pleurectomy, pulmonary artery reconstruction with a prosthesis, and as well as the pulmonary valve with a biologic valve. And the pathologic report, as many of you had probably thought about, was an intimal sarcoma with molecular confirmation of MDM2 amplification. The tumor was quite big, 8 centimeters, and in some points the surgical resection margin was positive. A quick question for you. Do you have access to molecular diagnosis in your centers? Okay, so the majority of you have access to at least FISH. Perfect. So in the surgical, in the post-surgical control, the CT scan performed in the 25th of March this year, no clear signs of macroscopic residual disease were seen. You can see here the processes in the pulmonary artery and the effusion in the pneumectomy residual cavity. So at that point, she was referred to our center. She came being quite frail because she was in the immediate postoperative period, a little bit short of breath, but she had just been pneumectomized. And as already said, no clear evidence of macroscopic disease with the exception of doubtful internal lymph nodes in the mammary area, in the internal mammary area. So we faced a 34-year-old woman with a molecularly confirmed intimal sarcoma already resected with a Errani resection. So that's my question for you. What would you do next? Start a close follow-up, re-excision to improve surgical margins, adjuvant chemo, and in that case we will discuss with which regimen and number of cycles, adjuvant radiotherapy, and with which technique, or adjuvant chemoradiotherapy. Okay, so the majority of you think chemo and chemo plus radiotherapy. Those who don't go for the combo go for adjuvant chemo. So the majority, 77% of the audience think she should receive chemotherapy, and 15% would just follow up. So Sabrina, I would like now to see what are the thoughts of the panel.
So Sharif, do you want to start?
Yeah, I can start. Actually, that's a very interesting case. I think in the intimal sarcoma we had in the past, we did about everything that you proposed, any option, which is stop, nothing, chemoradiotherapy, and it all failed miserably. Most of the patients relapsed. Actually, the only one who enjoyed 15 plus years of disease-free interval was treated with chemo and radiotherapy, but developed a lung carcinoma on the site irradiated and died of that. So nobody really knows, actually. My last failure was a cardiac transplant, and I presented actually to this session. You may remember, yeah. She died actually months ago, 2 years after the brain mets. And
did they accept the indication of a cardiac transplant?
Actually, we debated for both a relatively long time, but not such a long time for the cardiac transplanters. She was after 6 courses of adjuvant because she was resected, but R2, okay. No residual lesion visible, 6 AI, then CR still, 22-year-old. She was proposed and accepted for emergency cardiac transplant. And it was a mistake because she relapsed brain 1 month afterwards, but was okay during 2 years with the brain mets.
Interesting.
Yeah.
The brain relapse.
She never had anything else in brain relapse.
Wow.
Could I ask a question now, because there is always, the studies about NDM2 inhibitors and all the things. So it's always, the patient with the intimal sarcoma seem to me, be in need of something like that. So where have anybody tried it or?
We have an open study which can include with an MDM2 plus CDK4 inhibitor, HDM201 and ribociclib, actually, where we can put intimal sarcoma. At this stage of the study, what I can tell you is that there are no big responses, but some patients enjoyed stable disease.
Yeah, we are about to open also a phase 1 trial with an MDM2 inhibitor accepting intimal sarcoma patients. But I don't have experience specifically in intimal sarcoma patients. So Axel, have you done chemotherapy, or what would be your?
Yeah, I don't know if I am right, but all patients were seen in our team receive adjuvant chemotherapy. It is always an R1 resection at least, if not an R2. But even for all R1 resection, I propose adjuvant chemotherapy, doxorubicin combination, 5 to 6 courses. We have to collect all the patient to see what's happened. In some case, but very rare situation, radiation therapy, but in general, it's too complex localization for radiation therapy, specifically after large surgery. So what news in the intimal sarcoma for me, I have seen some tumor shrinkage, objective response rates with a combination of navelbin cisplatin. I don't know why, but it's only a message. Oral cyclophosphamide for some patient having a local relapse in the arteria, in the intimal arteria. Oral cyclophosphamide, I have seen tumor shrinkage. We have found an NTRK3 gene alteration in an intimal sarcoma.
With confirmed MDM2 amplification, right?
Yeah.
So both things.
Both.
So intimal sarcoma, so now we try to find other NTRK gene rearrangements in intimal sarcoma. It's a surprise because with it's a simple genetic sarcoma, so an amplification. We have just also find an NTRK gene alteration in a liposarcoma MDM2 amplified. And I know in the paper recently just published by the group, there is at least 3 liposarcoma, dedifferentiated liposarcoma with MDM2 amplification with NTRK rearrangements. So it's unusual results.
This is very strange because we all thought that it was a major driver, the amplicon, and actually it's possibly not, because a lot of people have observed that. I was discussing with Cristina Antonescu, who also had observations of NTRK fusions on MDM2 and CDK4 amplified tumors. That's very strange. This may explain why we are not so successful with MDM2 CDK4 inhibitors.
Exactly. And the other message is also, don't rule out NTRK testing in patients with unidentified MDM2 amplification, because classically they have said if you have another molecular alteration, probably the patient is not going to have an NTRK rearrangement. But in this case, it's worth.
So what did you do?
Those patients respond to NTRK inhibition, or is it just like bystander?
I don't know. Maybe.
No treatment yet in our hand.
Yeah, exactly.
So Nadia, what did you do?
Maybe I can come to my slides, because there is a conclusion. So our decision was, well, the case of course was discussed in the tumoral board in the sarcoma MDT, and given the age of the patient, the diagnosis, their at least R1 surgery with doubt on that lymph nodes, we have advised her for 3 to 5 cycles of adjuvant epi-E4. We use more epirubicin than doxorubicin in the perioperative setting. The possibility of a radiotherapy was also discussed in the tumor board, but our radiotherapy oncologist thought that it was not possible, even with protons. We have access to proton therapy in Spain since last year, but they said that due to the doses and the extension of the field, that was not possible in this case. And in the event of future progression, which probably will happen, let's hope not, but probably will happen, we also have this clinical trial with an MDM2 inhibitor, which is a basket trial. So, as you have already said, there is scarce data on the role of perioperative chemotherapy, or even chemotherapy in intimal sarcoma. Probably the most complete study is this retrospective study from the World Sarcoma Group, published by the Milanese colleagues and Amaya Frezza and colleagues, in which 72 patients with confirmed intimal sarcoma worldwide were included. 24 of these patients had localized disease and were treated with chemotherapy in the perioperative setting. And these are the figures for anthracycline-containing regimens in the localized setting, median relapse-free survival of slightly more than 1 year, which is not very encouraging, but probably the figures without chemotherapy are worse, and a median overall survival of 50 months, which is it's not bad considering that the majority of them relapse in just 1 year. So among patients with advanced disease, anthracycline-based regimens have a response rate of 38%, which is not bad. This is higher than expected for other soft tissue sarcoma subtypes. Median PFS was 7.7 months in this series. Gemcitabine and pazopanib both achieved the expected response rate, less than 10% for pazopanib. Gemcitabine also remained in a modest overall response rate, and median PFS was between 3 and 4 months, which is more or less the expected for other soft tissue sarcoma subtypes. And as you have already discussed, lately in the last year, several MDM2 inhibitors are in development. The clinical studies are mainly in liposarcoma, but last year in ESMO was this small phase 2 trial was presented with data from I don't remember, 12 I think, or 10 intimal sarcoma patients, some of them showing response rates, but it's true that the median PFS was in line with this expected and reported for pazopanib or gemcitabine. Median PFS was 3.7 months and median overall survival about 1 year. So my take-home messages from this case would be that intimal sarcoma is of course an ultra-rare sarcoma. MDM2 amplifications help in the diagnosis. These are challenging because they develop in a very, very challenging location, and the management within an expert sarcoma multidisciplinary team is key. Anthracycline-based regimens have shown efficacy in retrospective series. We don't have prospective data on chemotherapy. The role of perioperative therapy is unclear, but given that these patients have such a bad prognosis, it's worth to consider and discuss with them. And we still have to see which is the role of MDM2 inhibitors in this context. That's all.
Nadia, thanks so much. It's just absolutely awesome. Very, very good case. Any comments on Nadia's discussion? Maybe in this context, I think you rose, of course, even further questions, but maybe I add a surgical question to this. How often do you consider in a R1 situation with open space, open compartments without barriers? How often do you consider re-resection? Does that make sense? What's your opinion on that? Shintaro, do you want to?
So in the situation, it's very extremely hard to reject the completely of the recurrent tumor. So it's very, really tough for surgeons, unfortunately.
And what about in the extremity? How do you handle it there?
Oh yeah, I believe that the intimal sarcoma is occur in the about the heart. So I never see the intimal sarcoma. Oh,
no, just in general. In the R1 resection. The question is re-resection in R1 situation.
I'm sorry, but I cannot understand this. So the re-resection, so for the soft tissue sarcoma?
Yeah, if you have an R1 resection, when do we perform a re-resection? Specifically, if we have an open space, right? No barriers, no anatomical barriers.
Mm-hmm.
I mean, anyone can answer.
It's we speak about intimal sarcoma, correct? Not so.
Well, intimal is one thing, but it's called not the general.
For an R1 resection in general, it depends on a lot of things. we have to discuss the files in multidisciplinary tumor board. Our favorite option today, for non-high grade sarcoma, grade 1 and grade 2, follow-up. And we reoperate the patient only in case of local relapse. It's not a standard attitude, but to avoid to reoperate 60% of our patients for nothing, because even in case of R1 resections, we don't find residual tumor cells in the reoperation. So specifically in anatomic region where a second surgery could be mutilating, in a thigh or in a buttock, can discuss case per case basis to reoperate the patient. But in general, we close follow up the patient by MRI every 3 months, and we reoperate the patient only in case of local relapse. And we have sometimes, frequently, good results because patients do not relapse. So it means it was an R1 resection without residual cells, which is only
Makes any difference for you if the patient has been operated in a non-specialized sarcoma center with a non-planified surgery?
Yeah, even in this situation. Okay. Yeah.
We tend to have different approaches, actually, even within the FSG, and I would be interested by hearing the approaches of all. Some centers are reoperating if R1 outside the reference center, if a non-programmated R1. There is a retrospective analysis, be cautious, which suggests that it may be slightly better. So as there is no homogeneous, we need a randomized study for that.
Yeah. No, it's an interesting point. Of course, in case of R1 resection with an MRI performed within the 1 month after the R1 resection, if there is no residual macroscopic residual cells, we are in R1 resection. Today, in our institution, we follow the patient carefully. For grade 1 and 2, grade 3, it's another.
I mean, I agree with you. This is my feeling, but it's not evidence-based research. So we need I follow my patient.
The problem, we have no enough surgeon for reoperate all the R1 resection. So
exactly.
It is due
but
to...
maybe it's better for patients, right? So sometimes. So yeah, it's a great question. It's another open question, and we need an answer as soon as possible. So another study, another randomized
to build the protocol, randomizing surgery, salvage surgery versus only observation. I think the level of refusal is very high.
Yeah, but you could do like the osteosarcoma study, which randomized chemotherapy, which is to follow the patient who refused.
No, exactly. So I think that patients that don't have a local recurrence and had a R1 surgery, you can discuss with patients and suggest a follow-up or resection. That we don't know the answer, so we can discuss the patients, and we could do this study, this prospective study, I think.
And to come back to the intimal sarcoma, it's always an R1 resection, even in a referral center, because maybe they have known the technique. The diagnosis is complex to make before surgery. And Nadia showed the patient, the first biopsy was negative, and so the specialist of intimal sarcoma in lung clinics operate upfront this kind of patient. It is always an R1 resection. So maybe they have known the technique to replace the artery, the pulmonary artery, like a leiomyosarcoma vena cava. If you maintain the vena cava, the patient relapse. So we have to make a graft. So it may be more complex in the arterial setting.
Do you think?
Go ahead.
Sorry, Errani, go ahead.
No, go ahead, Nadia. I was wondering what would you do for R1 resection? You in the race in Japan, in Switzerland, what do you do?
Yeah, I was a little bit impressed now how reluctant the surgical colleagues are. Actually, Costantino neither said what he really does, but I think here with us it's more the question. I think it's a little bit the pressure we should resect, because it was always thought from historically to do it. But I feel also more as you pointed out.
I would like to add something during my discussion before. We don't reoperate the patient only if the patient was operated with an en bloc R1 resection, not a morcellated R1 resection, or it's not the same thing. So marginal
that was
resection.
my question regarding the expertise of the surgeons performing the first surgery. If you think it was a correct en bloc R1 resection, or
if there is only one piece arriving to the pathologist and there is no residual tumor cells on the MRI postoperatively, it is a non-planned R1 resection, but with an en bloc resection, so it's different.
Any other comments on that?
For intimal sarcoma, even if always R1, most of the time the patient die of a distant disease. Yeah. So it's not only a question of quality of resection. In my poor patient I was mentioning, she was an R0 with the heart on the table, and she has a 3 millimeter minimal margin.
Yeah, well, if you have this tissue of intimal sarcoma in your hands, which pathologists next to surgeons do, this is so friable tissue, and you know this is floating in this movable area. No way that it is going to be kind of cured on the surgery, even if the resection of the blood vessel is R0. So it's you know lost at the beginning if you are not able to kind of combat it by systemic treatment.
Well, okay. I think I'm extremely happy about all these discussions. Nadia, great case. It also shows how we can interdisciplinary discuss and raise questions and see the others' disciplines' perspectives. I think this is the beauty of this format. I really love it, and I think we have seen a number of new questions that we could address in the future. Again, at this point, I would like to thank all the presenters. I mean, you did an excellent job tonight. You stole a lot of questions, a lot of food for thoughts. That's just awesome. Thanks so much. Also, thanks for all the panelists taking your time and all the listeners in the audience. In this housekeeping things, you all will receive again a confirmation of your participation. You will have this feedback survey. Please take a moment and fill it out so that we can improve in the future. I would also again thank the sponsors, PharmaMar, Novartis, Bayer, and Implantcast. And we will go now for the summer break. We will resume our webinar series again in September. And I wish you a good evening, a good summer, and hopefully see you soon again. Thank you so much. Bye.